Okay, I'm going to be talking about hematopoietic drugs. First, starting with iron deficiency and B12 and folate deficiency, having megaloblastic anemia. Then I'm going to start talking about the drugs for decreased blood production, how you can increase that. And then I'll talk a little bit about sickle cell disease treatment. So first, with an iron deficiency anemia, you want to treat for 4 to 6 months, and there are oral preparations, and then there are injection preparations for IM or IV. For the oral, they're ferrous form in the preparations. So you take it by mouth, and the adverse effects are GI disturbances. So someone could have like epigastric pain, constipation, black stools, things like that. And so that's kind of the first line treatment. But if someone isn't able to tolerate oral iron, or if they have a malabsorption problem or something like that, you can do the IM or IV treatments. So the parenteral treatments, you can do iron dextran, which can be done IM or IV. And the dextran has adverse effects for IM at the injection site. I mean, there's possible infection, inflammation, and discoloration of the skin, because the iron can actually turn the injection site brown for light-skinned people. And the IV can cause headache, fever, nausea, vomiting, and very rarely people can have a fatal anaphylactic reaction to it. So you want to start out with the test dose before you give them a full dose. One other complication of iron supplements is you can have iron overload, and that's where the iron just over deposits in areas like the heart and the liver, the pancreas, and other places. Other parenteral iron supplements preparations are complexes with sucrose or gluconate or carboxymaltose, and those are for IV only. And those, again, are for people who are unable to tolerate the oral iron. So now we'll move on to megaloblastic anemia treatment with people with B12 or folate deficiencies. You can tell they have a B12 deficiency. Obviously, by their presentation, they'll have neurological symptoms and general anemia symptoms. But in the lab, you'll see that they have an increased level of methylmalonic acid and homocysteine, and that's because of the pathways that B12 is a part of and rate limiting. So you have a backup of the parts that can't move through the pathway. So there's either oral or IM treatments of that. They can take an oral cyanocobalamin, and that's if they have a dietary insufficiency. So like people who are strict vegans and have a B12 deficiency might have to take an oral supplement. It can also be given IM, as well as hydroxycobalamin. Those can be both given IM, and those are for people who have malabsorption. So like if they have gastric bypass or lack of intrinsic factor, or something bowel related where they can't absorb it in the distal ileum. Then you have a folate deficiency possible, which isn't very common in the US because a lot of our foods are fortified with folate. But some other things can cause a folate deficiency, such as medications like methotrexate, anti-seizure meds like phenytoin, and trimethoprim would also cause that. If you have a deficiency in folate in a pregnant woman, that can cause neural tube defects internally in the baby. So it's really important to prevent that, and you can give the patient an oral dose of 1 milligram pill to take daily to supplement. And they would have increased homocysteine lab values. So folate is only increased homocysteine, and B12 increased homocysteine and methylmalonic acid. So if someone has a B12 deficiency, you can supplement them with folate to supplement and correct the homocysteine levels, but it wouldn't correct the methylmalonic acid. So you have to supplement with B12 if it's B12 deficiency, and a lot of times you just treat with both. So if you have a patient who has not making blood like they're supposed to for one reason or other, chemotherapy or cancer or different things. You would start with stimulate these medications would stimulate red blood cell production. They're eopoietic. So by IV or subcutaneous injection, you can do eopoietin alpha, darbepoetin alpha, or peginacetide, and they have different dosages that are individualized based off of the patient's reaction to those dosages. So it's individualized of how you dose it. But eopoietin alpha, you'd give 3 times a week. Darbepoetin, you'd give 1 time a week. And then peginacetide, you give 1 time a month. So a lot easier to comply with. The mechanism of action of these is they bind to the EPO receptors on the progenitor cells that make red blood cells, and they stimulate their production, and so they increase proliferation and differentiation of red blood cells. And oftentimes an iron supplement is given in conjunction with an EPO agonist because they require iron to create the heme. Adverse effects of the RBC production drugs are it increases your risk of hypertension, stroke, MI, and heart failure, and that would just be kind of intuitive because of the increased blood production. Next, we'll move on to the drugs that stimulate white blood cell production. These are given IV or SC, and it's kind of a stupid way that I remember that they're white blood cell production drugs is because in their names it says like grass stain, so kind of like grass stain. So like you don't want a grass stain with like a white shirt, you worry about grass stain. So with a white blood cell deficiency, you worry about grass stain. So these are for people who have chemotherapy-induced neutropenia, filgrastim, and TBO filgrastim. You take those daily, and their adverse effect would be bone pain, as well as pegfilgrastim. That's 6 milligrams, and that's only a single dose you take each cycle of chemotherapy. And the adverse effect is also bone pain. Sargramostim system, you take 25 micrograms per meter squared per day, and the adverse effects are a lot more. There's arthralgias, myalgias, pleural and pericardial effusions, fevers, and peripheral edema. So a lot more adverse effects with that and higher dose. The mechanism of action is they stimulate neutrophil production, and also they enhance the function of them, the phagocytic function of them. And then we have the drugs that stimulate platelet production. You have oprelivin, and that prevents the thrombocytopenia secondary to cancer chemotherapy. It can be given subcutaneously. It started 6 to 24 hours after chemotherapy is complete, and you use it for 14 to 21 days or until the platelets are greater than 50,000 per microliter. The adverse effects are fatigue and fluid retention and atrial fibrillation. Another couple of drugs are altortrombide and rimoplostim, and those are used to treat for refractory idiopathic thrombocytopenic purpura, or ITP. The adverse effects for rimoplostim is they're generally well tolerated, but they can cause a mild headache. And then the eltrombopay is adverse effects are hepatotoxicity and increased risk of hematological malignancies. So that one has a lot more adverse effects. So I would stick with rimoplostim or oprelivin. So I'm going to go a little bit over a sickle cell treatment. The only one that's FDA approved in the US is hydroxyurea. So we know that it increases the fetal hemoglobin in sickle cell patients up to 20% of the total body hemoglobin, and the mechanism of action is not really known, but it might be because it blocks the division of the sickle cell hemoglobin, so it would cause reversion back to hemoglobin, the fetal hemoglobin. And it might reduce the number of white blood cells and platelets, which reduces their role in vascular injury. And then it might cause vasodilation because the byproducts of hydroxyurea breakdown is nitric oxide, and nitric oxide is a natural vasodilator. So it's thought that maybe the vasodilation just decreases the damage done by the sickle cells. That was a bad one.